This webinar is part 2 of the lecture on vascular distensibility and functions of the arterial and venous systems. This part of the lecture will cover how to take blood pressures, mean arterial pressure and its calculation, and also looking at the venous system and venous pressures. So the first thing is the measurement of arterial blood pressure. We will be doing what is called the auscultatory method of taking a blood pressure. So we will be listening for sounds in order to take a blood pressure. This is an indirect measurement of taking a blood pressure. It's less invasive, and more patients are willing to have your blood pressure taken this way instead of doing directly by having to do an arterial cut down. So we will be doing this in lab, and you will be doing this with your patients. So what will happen is you're going to take your sphygmomanometer, and on the sphygmomanometer it has a cuff which is placed around the arm. And in lab I'll teach you specifically how to line it up on the arm. You will place your diaphragm of your stethoscope over the brachial artery. What you're going to do is you're going to start to inflate the cuff to the point where the brachial artery is completely collapsed. When that happens, there'll be no blood flow going to the hand. So hopefully you can take a blood pressure fairly quickly, because your patient will not like you if you don't restore blood flow fairly quickly. Well, what will happen is you're going to slowly let the air out of the cuff. And as the air is let out of the cuff, what you're going to notice is I have no blood flow when it's above the patient's systolic pressure. But if you let the air out of the cuff to the point where the cuff pressure is below the patient's systolic blood pressure, you will get flow through that vessel, but it will be pulsatile. It will pulse through during systole, because systolic pressures is enough to get that vessel open and blood through, but the pressures in the cuff are greater than that patient's diastolic pressure, so the vessel will collapse again during diastole. So you're going to be hearing this, what we call carot cuff sounds. And in your manual, the carot cuff is spelled incorrectly. It's K-O-R-O and not K-A-R-O. So carot cuff sounds are sounds that are created by turbulence. Because what you are doing is you're creating turbulent flow in that vessel. So the blood pulses through that vessel. During systole, it collapses, and then you don't hear anything. So you're going to hear thump, thump, and every time you hear something corresponds to the heartbeat. So if you're actually taking a pulse at this, or if you're taking a pulse on the other arm at the same time, it will be going along with a heartbeat. So as you continue to let the air out of the cuff, when the cuff pressure is less than the patient's diastolic pressure, you will restore what we call laminar flow to the vessel. You will have no turbulence and no sounds, and so the sounds disappear. So the pressures here are for Guyton-Man pressures, but this will be different depending on who your patient is. So you can say cuff pressure is greater than systolic pressure. No flow means no sounds. You're not going to hear anything. When you let the air out of the cuff and the cuff pressure is between the patient's systolic and diastolic pressure, you're going to hear these carot cuff sounds, which are turbulence created by that pulsatile flow through that vessel. So it goes through during systole, but it doesn't go through diastole. When the cuff pressure is below the patient's diastolic pressure, you've now created laminar flow. There'll be no sounds. So one thing though, and I want you to emphasize this, you will not hear anything over that brachial artery if you have laminar flow. You're only going to hear something if you have turbulent flow. So do not place your stethoscope on your subject's arm and expect to hear something unless you create turbulence. If you don't have that cuff pumped up and you started to let the air out, you're not going to hear anything. If you do, I'm going to start to worry about that patient, that maybe they've got some sort of blockage in their blood vessels in their arm. So you shouldn't hear anything over that vessel if you have laminar blood flow. So if you look at this picture, this kind of goes through the same thing. If the cuff pressure is above systolic, no sounds. as the cuff pressure just drops below systolic, of course that's spelled wrong, drops below systolic, you're going to hear these tapping sounds, and it starts off very soft. The first sound you hear, and it's going to be soft, is the patient's systolic blood pressure. The sounds will get louder, and then when the sounds, they'll start to muffle and they'll go away. For you guys, you record when the sounds go away. A lot of nurses are required to note when the sounds muffle and also when the sounds go away. Things wrong. But you guys, it's okay if you just record when the sounds go away. So, first sound you hear, you're going to notice on the gauge where the pressure is, that is the systolic blood pressure. When the sounds disappear, that will be the patient's diastolic blood pressure. You can calculate a patient's mean arterial pressure if you know their systolic and diastolic blood pressure, but I'm going to show you that in the second one. First equation for mean arterial pressure that you need to know is this top one. Mean arterial pressure is equal to cardiac output times total peripheral resistance. Now, mean arterial pressure is important, very important pressure. It is the average, it's indicative of the average pressure that's in your cardiac system. It is a driving pressure that drives blood to tissues. So you must have an adequate mean arterial pressure to get proper perfusion of your tissues in your body. If the blood pressure is too low, not enough oxygen, not enough nutrients, you're not going to get rid of waste products, not going to be happy. You don't want it too high either, because you can damage, the high pressures can damage blood vessels, in particular organs. So it's very important that we keep mean arterial pressure regulated. Well, mean arterial pressure, one of the equations if you look at is the one I just mentioned, cardiac output times total peripheral resistance. Another way of writing it out is mean arterial pressure is stroke volume times heart rate times total peripheral resistance, because this is the equation, the stroke volume times heart rate is the equation for cardiac output. So that's just another way of writing that equation. If you notice that this equation for mean arterial pressure is just the equation for flow. It's the flow equation. The Q is the cardiac output, the delta P is the mean arterial pressure, and the R is the total peripheral resistance. So if you know the flow equation, you actually know the equation for mean arterial pressure. We've just rearranged it. So when it comes down to memorizing things for exams, you can limit the amount of memorization you do if you actually know the equation for flow. And total flow is your cardiac output. If you look at this equation, what you'll notice is if I keep cardiac output the same and I change total peripheral resistance, I can change mean arterial pressure. If I keep total peripheral resistance the same and I change cardiac output, I can change mean arterial pressure. So these things can affect mean arterial pressure. One thing though I want you to remember always is your cardiac output and your mean arterial pressure are independently regulated. So always keep that in mind. So if I want to keep my mean arterial pressure constant in a normal range, generally what's going to happen is if you assume, which usually holds true, your cardiac output regulation is normal. If I change total peripheral resistance, I will change mean arterial pressure. If I increase total peripheral resistance, my mean arterial pressure will go up. If I decrease total peripheral resistance, my mean arterial pressure will go down. But if you change, say, increase cardiac output and decrease total peripheral resistance, mean arterial pressure may not change. I wonder what scenario that may hold true. Maybe during exercise, when cardiac output is going up, my mean arterial pressure may not be changing that much because of enough of drop in total peripheral resistance that may be happening at the tissues that are getting all that blood. They may be dilating. So I'm just want to show you that you can have an increase in cardiac output, but mean arterial pressure not change. So, but the thing is, if you change cardiac output and you keep total peripheral resistance the same, yes, mean arterial pressure will change. Now, the other equation for mean arterial pressure is this one here. Mean arterial pressure is equal to 1/3 of your pulse pressure plus your diastolic blood pressure. So on the left, if I give you someone's blood pressure, say 120/80, you should be able to first calculate pulse pressure because it's systolic minus diastolic. So here it's 40 millimeters of mercury. This is a normal pulse pressure. So this is our Guyton-Man numbers. So what is mean arterial pressure? If I calculate it, 1/3 of 40, and this is what you do. This is, please make a note, write this down. Don't just take a mental note. You need to write this down. When you calculate mean arterial pressure, you will not take 0.333 times pulse pressure. That is not accurate. The most accurate calculation would to take the pulse pressure and divide by 3. Do not take pulse pressure and multiply by 0.3333333. Take your pulse pressure and divide by 3. Okay? With that saying, if you do it the other way, I will mark you wrong on your exam or quiz. So, in this case, 40 divided by 3 plus 80 is about 93 millimeters of mercury. Blood pressures, you should always round to the nearest whole number. So you shouldn't give blood pressures in 93.333. You should just say 93 millimeters of mercury. So here's your units. Now what you'll notice, I gave you another example. Here's someone's blood pressure, 107/97. Well, their pulse pressure is only 10 millimeters of mercury. That's a low pulse pressure. So this patient, I can tell you that their pulse can barely be felt. All right? But the reason why I have this up here is I want you to notice that despite this pulse pressure being so low, the patient's mean arterial pressure is not low. So pulse pressure has nothing to do with the mean arterial pressure. Okay, so if I have a low pulse pressure, does not mean I'm going to have a low mean arterial pressure. So you'll notice when we calculated this person's mean arterial pressure, it's about 100 millimeters of mercury. Well, Guyton says, just to make it easier to remember what's considered a normal mean arterial pressure, he says 100 millimeters of mercury. So according to Guyton, that's a normal mean arterial pressure. In reality, that mean arterial pressure is a little bit high because generally we're going to use more Guyton numbers. And Guyton numbers are 120/80. And there's in which I got about 93. They give you kind of a range. This is the numbers I want you more to remember for a normal mean arterial pressure. The normal range is somewhere between 90 and 96 millimeters of mercury is considered to be normal mean arterial pressure. So less than 90 is considered to be low. Higher than 96 is considered to be high. But despite this patient's really low pulse pressure, their mean arterial pressure is not low. If anything, it's a little on the high side. So always keep that in mind, that pulse pressure and mean arterial pressure do not go hand in hand. What you notice, though, for this equation for mean arterial pressure, most of you are like, well, okay, what does mean to you? It means average. So if someone's blood pressure is 120/80, I would add the two numbers together and divide by 2. To me, that's average. So I would get 100 millimeters of mercury. But you can't do this for mean arterial pressure because we spend about 2/3 of the cardiac cycle under resting conditions in diastole. So mean arterial pressure is always closer to the diastolic pressure. That's why you see this equation written like this. So don't just take the systolic, diastolic, add them together and divide by 2. That's not the way to do it. You have to take 1/3 of the pulse pressure plus diastolic because mean arterial pressure is a little bit closer to the diastolic than it is to the systolic blood pressure. Now, if you look at mean arterial pressure in systolic and diastolic pressures. As we get older, there's some changes that happen. As we get older, systolics, diastolics, and our mean arterial pressures all appear to increase. Now, how much it increases depends on the individual, but if we're looking at the entire population, these numbers will tend to increase as we get older. The reason why all these pressures increase is we do get changes in the kidneys, which play a very important role in blood pressure. And usually the kidney changes are more significant after we hit 50. And we do start getting a little bit of the hardening of the arteries as we age too. And so that does happen as we get older. It's just an inevitable process. Generally, I will tell you everything goes downhill as you get older, except your blood pressure. So these do tend to increase as you get older. That's why it's real important that if you're 20 years of age and you've got a really high blood pressure, you need to get it in check because it's going to get worse as you get older. Now, the last things that we're going to be looking at is the veins. And if you talk about the veins and their functions, you have to mention pressures in the veins. Now, we mentioned veins. The biggest function of the veins is storage, yes. So, but we also have to talk about pressures when it comes to the veins. In general, pressures in the veins are not that high. I know it's a lower pressure part of the circulation than in the arteries. I want to talk about a couple pressures, and these are venous pressures. A peripheral venous pressure, which makes sense. The top one doesn't make quite as much sense, but let's look at the bottom one first. A peripheral venous pressure is the pressure in the veins in the periphery. Okay, so in the periphery. Right atrial pressure has another name. Right atrial pressure is called central venous pressure, or you can abbreviate CVP, all capital letters. Right atrial pressure can be abbreviated as RAP, all capital letters. So this one kind of, when I first had learned about this, I'm like, this doesn't make sense. If you say right atrial pressure to me, I'm thinking pressures inside the right atria. No, they use this for the pressures right before you get to the right atria. I don't know why they did that because it's confusing. Central venous pressure makes more sense to me. But the pressures, the right atrial pressure or the central venous pressure is the pressure taken in the vena cava right before you enter the right atria. Okay, so that's where that pressure is recorded. The right atrial pressure or the central venous pressure, the normal value should be about 0, very close to 0. I know some textbooks are going to give you slightly higher numbers, but they should be very, very low. Now, the pressures can increase under certain conditions. Now, before I mention that, I want to explain why it should be really low. As pressures, as you go from aorta down to the arteries to arterioles on down, pressures do decline because of friction. By the time we get to the capillaries, we want it kind of low, and it continues to drop. As long as you have a pressure gradient, blood will continue to move along in the circulatory system. You want pressures in the right before you hit the atria low so you can make sure blood is coming back to the heart. Because if pressures start to increase there, it's going to oppose blood coming back to the heart. So you want to keep those pressures low. Well, things that can result in increases in these pressure, if you have an enormous increase in blood volume, that could. If you increase venous return, which kind of would increase blood volume, okay, you got a lot of dilation of peripheral of the arterioles. Eventually, that would increase a lot of blood back to the heart. It could, and you notice I keep saying it could, and there's a reason why I keep saying that. If you have an increase in that peripheral venous pressure, it's going to drive more blood to the heart. That could potentially increase that pressure. But generally, we have, if everything's working normally, and the heart's, I should say the heart's working normally, those pressures will not increase because the heart will pump that blood away. So if the heart's working okay, that usually doesn't happen. But if the heart is failing, those pressures can increase significantly, which would kind of think will kind of be kind of a I don't really think it's protective, but it is kind of protective in a way, is I'm not working, I can't deal with all this blood, stop bringing me blood. Even though we know in reality that's not really smart, but it would start opposing more blood coming back to the heart, which in reality is not a good thing. You can have those central venous pressure become subatmospheric. This doesn't happen very often, but you could see this if the heart's pumping very forcefully, which you may see in some endurance or elite athletes, where if the heart is pumping blood out so forcefully that those pressures can become subatmospheric. It can't get too low because the veins would then collapse. So it has a lower limit. If you talk about the veins and pressures, you also have to talk about resistance. So if you look at resistance in veins in general, just think about it. Not a lot. The veins don't provide a lot of resistance to flow. If you have, if you look at the large veins and they're fully distended, the resistance is pretty much nothing. So I mean, usually it's not all that important, but anatomically, in certain places in the body, there is some resistance in the veins. So examples would be as the veins enter the thorax. So you got veins entering the thorax, you can get some compression. You can also get compression of veins in the arms at the first rib, just because the rib's compressing it. You have low pressure in the neck just because of atmospheric pressure. It tends to collapse the veins in the neck. You also can get compression in the abdominal veins, especially if you're laying down and you got a lot of weight on top of those veins. So you can get some resistance to flow there. Okay, so we do have some instances of resistance normally, not an issue. Now some pressures, if we talk about peripheral venous pressure, there's a number I want you to remember. Peripheral venous pressure, which is kind of driving blood back to the heart, should be about 7 millimeters of mercury. Okay, it's about 7 millimeters of mercury. As long as you have, a pressure gradient from the veins, the peripheral veins, to the heart, you will get flow back to the heart. Now, what would happen if the right atrial pressure started to increase? Okay, just think about it. Blood's going to back up. What's going to happen? Blood backs up into those larger vessels. They start to open up. The peripheral resistance is not going to increase until all the vessels are open. Now, if there is all this blood backing up, the peripheral venous pressure may start to increase to try to get blood back to the heart. That may happen. Okay, but one thing again I have to remember, in order for right atrial pressure to start to go up too high, the heart has to be greatly weakened for that to happen. That's generally what would happen to cause that right atrial pressure to be so high. Now, if you have a lot of pressure, say, on the abdominal, in the abdominal region, you may have a corresponding increase in pressure in the peripheral veins, which would try to get that blood back to the heart. But here's where something could happen. If that pressure gets too high, that pressure actually will be transmitted back to the capillaries, which are thin-walled. And if that happens, you can have edema that forms, leakage of fluid out of the capillaries, and edema can develop in the lower parts of the body, which may happen under a few circumstances. If you're pregnant, you got a lot of babies sitting there on top of those veins. Pressures go up. They tell you not to lay on your back because that's going to create a lot of pressure there. A lot of pregnant women start to get a little edema in the feet, a little swelling. They would call them the cankles. Okay, so they get kind of the elephant ankles. You can also get that if you have a tumor in the abdominal cavity. You can put a lot of pressure there. and that had happened to me. I had a very large tumor, actually my pelvic cavity, put a lot of pressure, and it made I have varicose veins in my legs, and it made them a little bit worse. And I didn't get a lot of problems though with edema, peripheral edema, thankfully, but it did kind of make my varicose veins a little bit worse. You also, if you get accumulation of fluid in the peritoneal cavity, to describe to you, which are not in your notes, before I talk about the venous pressures some more and arterial pressures, is the difference between hydrostatic and hydraulic pressure, because I'm going to be talking about the effects of gravity on your venous and arterial pressures. So when I talk about the effects of gravity, I'm talking about hydrostatic pressure. Hydrostatic pressures are also known as gravitational pressures, because if you have a column of fluid, if you go at the top of the fluid and you measure the pressure down at the very bottom, the pressure at the very bottom is going to be the highest because of the weight of the fluid on top of it. So hydrostatic pressure has, if you're standing upright, is going to play an important role in measured pressures if we look at the circulation. Now, when I talk about later on in later lectures about different pressures, I will talk about hydrostatic pressures. And when I say if I'm mentioning your capillary hydrostatic pressure, I'm referring to that pressure in the capillaries that's pushing against the side of the vessel wall, and it's trying to push things out. So I'll mention things like hydrostatic pressures, and I'll also mention osmotic pressure. So that's going to be the later date. Now, if we look at hydraulic pressures, those of you who are car people know what hydraulics are. I'm not a car person, but hydraulic pressures is a pressure in a system that has fluid in it that's created by a pump. And when I'm referring to our cardiovascular system, your hydraulic pressure is created by the heart. So if I want to look at pressures in your circulation, you have to take into consideration the pressure created by the heart, but also the pressure created by gravity. So let's look at an upright person, so our little stick figure person, and we're just going to look at venous pressures. So here's the heart. Venous pressure at the level of the heart should be 0. Don't have to memorize all these numbers. What I want to show you, as you move down in an upright person, down towards the feet, the venous pressures will steadily increase. And the reason why they steadily increase is not because of hydraulic pressure, it's because of gravitational pressure. About the level of the feet, it's about 100 millimeters of mercury venous pressure in an upright person who's standing still. That's the effects of gravity. So as you move down, the highest pressures are actually, we should have this down here, the highest pressures will be measured at your feet. As you move up towards the head, pressures decrease. And you notice up here in the subdural sinuses, it's negative, a negative number. Don't worry, it's not cause a problem because that's in a non-collapsible chamber, so it's not much of an issue. But you'll notice, so big thing I want you to get first is the highest venous pressures are measured in an upright person at the feet. Lowest will be up at the head. Now, if this person was lying down, they're going, lying down, you don't have the effects of the gravity as much. So the pressures, if I was measuring the pressure at your feet, they would not be 100 millimeters of mercury because the size of the fluid column is lower if you're lying down than when you're standing up. Now, if we talk about arterial pressures, we would have to add the pressures in response to the pump. We have to add hydraulic pressure with a hydrostatic pressure. So if I said arterial pressure, at the feet they'd be like 190 millimeters of mercury because you've got the pressure created by the heart, but also the pressure created by gravitational pull. So what's so significant about this? Who cares? There's a difference between the effects of gravity. It is pretty important. If I'm standing upright and I'm not moving, what can happen? An example would be your soldier, you're asked to stay at attention. Okay? Very quickly, pressures in the feet can increase to like 90 to 100 millimeters of mercury in like less than a minute. Okay? I had mentioned earlier, though, pressures in the veins, they increase. It can be transmitted to the capillaries and result in fluid leaking into the interstitium. And you can get about 10 to 20% of your blood volume lost in a matter of maybe 15 minutes. And some soldiers have been asked to stand that long at attention. Okay, so you're standing at attention, not moving, which you really should move, but there's a way of tricking it that you don't look like you're moving. Pressures can increase. You get a significant amount of fluid loss. What will happen is you end up with getting less blood going back to your heart. It's all down there at the feet now. So a decreased venous return would result in a decreased end diastolic volume, which would do what to your cardiac output? Decreased end diastolic volume, you're going to have a lower cardiac output. If that's maintained, you're going to have reduced organ perfusion, which includes the brain, and the person's going to pass out. That's probably, passing out is probably a good thing, because you pass out, you're going to be laying down, and now those venous pressures aren't going to be so high, so hopefully you'll wake up. Okay? And so what was a way a soldier can avoid this from happening? And I've had plenty of people, students that were soldiers, and they have seen plenty of people that have been forced to stand at attention for long periods of time that passed out. They have little tricks, and you can see this also with the soldiers that stand at up in where the Queen is, and people always go try to mess with them to make sure they move, and they're not supposed to move, otherwise they get fired. They have to stand at attention. Well, they got clothes on, so you can't tell what they're doing underneath their clothes. They always tell you to pull up your kneecaps. So you're kind of contracting the quadriceps. And so you're kind of doing some little bit of skeletal muscle movement, which will help to get blood going back to the heart. And also kind of the slight movement is reducing the effects of gravity. If you're moving, those pressures in the feet don't get to 90 to 100 millimeters of mercury. Maybe 30, but not 90 to 100 millimeters of mercury. So this leads us, me mentioning to you about movement and contracting those skeletal muscles, how it helps getting blood back to the heart. And another thing I want to talk about was something else that can reduce the effects of gravitational pressure. What we have here are some means in which we try to ensure we have blood going back to the heart, from the venous system. Because the venous pressures are really generally not all that high. And we got to go against gravity. We got to move that blood going from the feet back up. So what ways can we ensure that we're going to get blood back to the heart? Well, I put stars by these two for a reason, because they are the most important ones. So let's talk about the muscle pump. So here's someone's leg, and if they're moving, the muscle is contracting, squeezing on the vein, so they're going to relax, contract as they're walking, relax, contract, relax, contract. That's going to kind of push blood back up towards the heart. So movement itself helps to return blood back to the heart. What also helps in this is the fact that you have valves in a lot of your veins. And so what happens is the blood moves up. Okay, relax. Why doesn't it just drop back down to your feet? Well, these valves close back up so it doesn't go back down. So it goes up, valve closes so it can't come back down. So it keeps going up. Now the valves, you can write this down. What they do is, besides what you have in your notes, is they reduce the gravitational effects on peripheral venous pressure. So they reduce the gravitational effects on peripheral venous pressure. They break up the size of this fluid column. So you don't have all this weight down here because we've broken up the size of the fluid column. So this is an important means of getting, making sure that we can help getting blood back to the heart, but these two are the most important. But one thing I want to mention about valves, the valves in veins are not found in the thoracic or the abdominal cavities. So if you have veins in the thoracic or abdominal cavities, there are no veins. You're going to see it down, say here, down in here. Once you get up into the abdomen and the thorax, no veins. Okay? So, do arteries have valves? I hope you said no. Arteries don't have valves. Veins do. Your heart chambers have valves, but arteries don't. Okay? Lymphatic vessels also have valves, and we're going to talk about that at a later date. Now let's talk about the respiratory pump. That's also one of our big stars. Respiratory pump is the fact that when you breathe, if you inspire, what it does is it helps to bring blood back to the heart. So the inspiration, the changes in thoracic pressure that result from inspiration helps to ensure venous return back to the heart. So breathing helps to bring blood back to the heart. So those are considered the most important means of getting blood back to the heart. Now, one thing I do want to mention about the importance of movement in maintaining venous return, and also the importance of movement, just keeping blood moving, is if you have blood not moving, stagnant blood tends to clot. And so your risk of blood clots go up quite a bit if you're not moving. So people that are bedridden, they wear compression stockings, or they have, instance when I had surgery and I wouldn't be able to get out of bed, and during the surgery they had these things that were wrapped around my lower legs that periodically inflated to compress my vessels and then relaxed to kind of act as its own pump to make sure that blood was going to continue to go back to my heart. If you're on an airplane for a long period of time, they tell you to kind of get up and move around periodically, because that stagnant blood is going to tend to clot. And a lot of people die each year from what we call deep vein thrombosis because of not moving. You get these blood clots that develop. It happens a lot of times on airline flights. Now, a couple other things that can help with venous return to the heart is venomotor tone, that refers to the tone or tension, think tone and tension of the veins. And again, veins do have some smooth muscle, okay? So if the smooth muscle contracts in the veins, that would decrease capacitance of the veins, but that would get blood going somewhere else, in this case going back to the heart. So in some instances, venomotor tone can increase blood going back to the heart. Also, you can get the effect of just the heart contracting, relaxing, kind of creates a suction effect. So, but this again is only really what you'll see in extremes in exercise and more the elite athletes. So this is not a real important one. These two are real important. The very, very last topic of this lecture is veins as blood reservoirs. I've talked to you many a time about the veins serving as storage, and I haven't gone back on that. They still are very important for storage. So if you constrict veins in response to the sympathetics, I can reduce the amount of blood in the venous system, getting it into the arterial system, which may play a role in exercise or if you're losing blood somewhere in your body. Now, there are some places in your body that we refer to as specific venous blood reservoirs. Not every vein in your body is about storage. Your spleen has about 100 mils of blood that it can give up if you stimulate your sympathetic. That's why you always have to be careful about injuries to the spleen, because you can lose a significant amount of blood in the spleen because the spleen is filtering blood. The liver has a good amount of blood too. But maybe, I think it's even more than 300 mils. It's in your notes, but it has a significant amount of blood. If I need to, I can borrow some blood from there and take it to somewhere else where I need it. Obviously, your larger abdominal veins, they're huge. They're going to be a great place for borrowing some blood for. You also have the venous plexuses of your skin, and this one will make sense to you if you think about, if you look at someone and they get really pale, and some people may get really pale if they're starting to lose a lot of blood, because they're taking the blood away from the skin to get to where the more important organs, the heart, the lungs, the kidneys. So you start to get very pale as you're borrowing blood from the skin. Now, a couple things to keep in mind is never, ever would you want to borrow blood from the heart and the lungs. They are not part of your venous blood reservoir. Blood volumes can change in the lungs and the heart, but not because you're borrowing from it. Because you don't want to borrow from lungs, because they're going to be the ones that are being oxygenated in your blood and get rid of CO2. And the heart is generating the pressures to get blood out to the periphery and up to the lungs. So you never want to borrow blood from these two places in your body. These ones, good idea. Okay, so the veins are pretty good places to borrow blood from. So this is the end of the lecture. And so what I will do, perhaps, is, let's